This animation shows how the levels of immunoglobulins change during the specific, adaptive immune response that develops as a result of infection with a pathogen or following immunization. When vaccine antigen enters the body, it triggers an inflammatory reaction. This is initially mediated by the non-specific innate immune system, but subsequently develops to involve the specific adaptive immune system too. Dendritic cells are attracted to the antigen. The antigens are taken up by the dendritic cells, also known as antigen-presenting cells, and presented on the cell surface membrane. They migrate to the lymph nodes. The primary specific adaptive immune response is now underway. T cells that recognize the specific antigen being presented by the dendritic cell bind to the antigen. This process activates the T cell to become a helper T cell. Meanwhile, immature B cells pick up the antigen on their surface immunoglobulins and process it. Once processed, the antigen is presented on the surface of the B cell. There are approximately 10 million different types of immature B cells. Each cell carries a unique immunoglobulin on its surface that can bind to only one specific antigen. The helper T cell binds to the antigen on the B cell and then releases cytokines that stimulate the B cell. Once stimulated, B cells undergo rapid proliferation and differentiation into plasma cells and memory B cells. One such B cell can produce thousands of daughter cells in a few days. This action increases the capacity to produce stronger binding, soluble antibodies. The antibody concentration rises in the blood serum. Further stimulation of B cells by T cell action leads to affinity maturation, where high-affinity antibodies are produced. The concentration of antibodies is now at a peak. Infection is over. The plasma cells die off and the antibody concentration falls. This is known as the contraction phase. The specific adaptive immune system retains memory of the antigen for future use. Memory B cells remain in bone marrow and may circulate between lymph nodes, ready to recognize the antigen again if it presents itself. They continue to secrete a low level of high-affinity antibodies. This is known as immunological memory. When the body is exposed to the same antigen again, These high-affinity antibodies in the blood bind to the antigen. This acts as a signal to circulating cells that recognize the antigen quickly, and the secondary response begins. Memory B cells and T cells are activated more rapidly than on primary contact with the antigen, as the antigen is already familiar to the immune system. The memory B cells proliferate and differentiate into plasma cells that produce high-affinity antibodies in higher concentration than found in the primary response. Often, during the secondary response, further maturation occurs, leading to the antibodies that are more specific. Consequently, each time the body is exposed to a particular pathogen, the antibody response becomes quicker, more sustained, and of higher affinity, offering even better immunological protection.
Hi, my name is Mober Mazari. I am an endocrinologist at the University of Ottawa in Ottawa, Canada. This is a short video abstract of the article Immune Checkpoint Inhibitor Therapy Associated Hypophysitis. This article is mainly about ipilimumab. Ipilimumab induces anti-tumor effect by activating the immune system against the cancer cells. The exact mechanism of action is illustrated in this diagram. Ipilimumab is approved for treatment of metastatic melanoma, and it is under investigations for treatment of other types of cancer. Multiple immune-related adverse events has been described in association with ipilimumab. Hypophysitis is the most commonly reported endocrine side effect. In this article, we described clinical presentation, diagnosis, and clinical course of 6 patients with ipilimumab-induced hypophysitis. All of the 6 patients had evidence of anterior pituitary dysfunctions. None of them had posterior pituitary involvement. 4 out of 6 patients had evidence of pituitary enlargement on MRI. This article includes a concise review of ipilimumab-induced hypophysitis. The following points are discussed in the article: clinical presentation, pattern of hypopituitarism, typical findings on cellular MRIs, pathogenesis, males versus females prevalence, and recovery of pituitary function. In the last part of the article, we discussed the prevalence of hypophysitis with other immune therapies used in cancer treatment, and we discussed some of the differences between ipilimumab-induced hypophysitis and classical lymphocytic immune hypophysitis. Thank you for watching this video abstract.